Assalamu alaikum. Thank you for having me here. So, today my topic is recent advances and approaches in gestational diabetes mellitus. Yeah. So the introduction, the definition of GDM is okay. Yeah. The definition is any degree of glucose intolerance which is first recognized during pregnancy. And again, it can be classified into A1 and A2. A1 GDM is GDM that is managed without medication, that is on diet and medical nutrition therapy, and the A2 is the one that requires either oral hypoglycemic drugs or insulin. Now the prevalence of GDM varies in India from 4.5 to 18.9. This depends on the screening test used, urban or rural population screen, ethnic and socioeconomic variation. So Telangana, the overall incidence the prevalence is around 8%, but again in Hyderabad, it's very high, it's around 15%. So this gestational diabetes is a disease that develops during the second or the third trimester of pregnancy, and it is characterized by marked insulin resistance secondary to placental hormonal releases. Causes are insulin deficiency, insulin resistance. Both result in hyperglycemic levels. Now, the etiology is beta cell dysfunction, impaired or delayed responses to the elevated blood glucose levels, insulin resistance predominantly induced by placental hormones. Human placental lactogen is the main hormone responsible. Additional contributing hormones are the growth hormone, prolactin, corticotropin releasing hormone, and progesterone. These hormones collectively contribute to the enhanced insulin resistance and hyperglycemia seen in GDM. Now, the risk factors. Risk factors are increased body mass index, that is more than 30 kg per meter square, previous history of any macroscopic baby, more than 4.5, previous history of any stillbirths, previous history of any gestational diabetes, any family history, high risk ethnic population, like Asians comes under the high risk ethnic group, and history of any PCOS, polycystic ovarian diseases. Now the pathophysiology, hormonal changes in pregnancy. The placenta starts to release the hormones after around 12 weeks. So that's one of the main reasons why GDM develops during the second and the third trimester. So human placental lactogen is the main hormone that is secreted by the placenta, and it is structurally analogous to the growth hormone, and it induces a critical metabolic adjustment, and this hormone is responsible to maintain the fetal nutrition. And it is capable of altering the insulin receptors, leading to insulin resistance. So the following molecular variations have appear to have links to diminished glucose uptake at the peripheral tissue. That is molecular alteration of the beta subunit, diminished phosphorylation of tyrosine kinase, and remodeling of the insulin receptor, substrate 1 and phosphoinositol. Now maternal high glucose crosses the placenta. They produces fetal hyperglycemia. The fetal pancreas gets stimulated in response to this maternal hyperglycemia, and they start producing excess fetal insulin, and this insulin has anabolic properties. This causes the fetal tissue growth, and that increases the weight. We have macroscopic babies. So this is the pathophysiology, insulin deficiency and peripheral insulin resistance. And what are the adverse effects of this gestational diabetes mellitus? On the mother, early pregnancy, if it is over diabetes like pre-pregnancy, there is increased risk of abortions and stillbirths. During pregnancy, associated complications like risk of preeclampsia, hypertension, excessive growth of the baby, hydroamniosis, that is excess of amniotic fluid, and higher incidence of any urinary tract infections. And during delivery, there is increased likelihood of preterm labor, potential risk of traumatic labor, instrumental delivery, cesarean section, and postpartum increased risk of any infections and hemorrhages and thromboembolic phenomena. All these contribute to an increase in risk of maternal morbidity and mortality. So yeah, the postpartum period, difficulty in initiating and maintaining of breastfeeding, and long-term postpartum infections and long-term consequences like risk of development of progression to overdiabetes and risk of cardiovascular complications in the future. Now the fetal and neonatal effect. Mostly neonatal complications include hypoglycemia, respiratory distress, polycythemia, hyperbilirubinemia, hypocalcemia, hypothermia, and polycythemia. So all these are the various adverse effects that can be seen in the baby. Childhood, increased risk of obesity and impaired glucose tolerance, and in adulthood, increased risk of development of hypertension, development of diabetes, coronary artery disease, and metabolic syndromes. Increased risk of CVS. Now, what's new in GDM? Why do we need to screen GDM? It's a perpetual controversy, like screening and diagnosis of GDM. What's the significance of screening? Whom to screen, when to screen, and how to screen? So what is the significance? First thing is, do we need to screen? Yes, of course we need to screen. This is based on what? A HAPO study, that is hypoglycemia and adverse pregnancy outcomes. The study was conducted around 15 centers in 9 countries, and participants, though they underwent a 75 grams oral glucose tolerance test, and the parameters were measured. These were the primary outcomes, that is increased weight, primary cesarean section rate, and neonatal hypoglycemia, and corporate C-peptide levels. So all those people who had increase in the blood sugar levels had a correlation, positive correlation between the increased maternal glucose levels and the frequency of each primary outcome. The secondary outcomes that were measured were preeclampsia, shoulder dystocia, premature delivery, NICU admission rate, hyperbilirubinemia. So there is a positive association. So that solves the why we need to do the screening. And the next question is, whom to screen? Should we screen everybody, or should we be doing a selective screening? Now, high-risk screening should be conducted in low-risk populations. The risk factors which were discussed earlier. Now, universal screening applies to screening in the entire population or a subgroup irrespective of risk factors. According to the ACOG, that is American College of Obstetric Gynecology, ADA, and International Association of Diabetes in Pregnancy Study Group, and DIPSI. DIPSI is Diabetes in Pregnancy Study Group India. They support a universal screening in Indian population because we fall under the high risk of developing GDM. So again, the next question is when to screen, whether one-step or two-step approaches, and these are the various guidelines, like NICE guidelines, that is mostly for the UK, 24 to 28 weeks, and they have a selective screening approach, that is high-risk population. ACOG has again 24 to 28 weeks, except those with high risk, they recommend to get an earlier screening done. ADA and IADPSG, first antenatal, and then 24 to 32 weeks, and DIPSI. What we follow is DIPSI in India. DIPSI is first visit. If normal, then again we repeat it at 24 to 28 and around 32 weeks. Okay, and national guidelines of India is the same, first visit, and then we repeat it around 24 to 28. Now, how to screen? So, a universal guideline for screening is lacking. So, there have been various programs and various guidelines according to the different associations. So, these are the different associations. The ACOG, it's a two-step procedure. They have a glucose challenge test, like 50 grams. After that, 2 hours, they'll measure the value. Do we have a pointer? Achha, isme. Okay. So, if that is positive, then we get the next step, that is the patient is supposed to come in a fasting state. We measure the fasting glucose, give a 100-gram challenge test, and these are the values: fasting 1 hour, and 2 hour, and 3 hour. And if 2 values are more, we label it as GDM. NICE guidelines are again one step, but it requires fasting and post-lunch. WHO again 75 one step. Fasting 1-2 hours, and IADPSG again 75 grams, again it is one step, fasting, post lunch, and 2 hours. Now DIPSI, in DIPSI we have an advantage is we don't get a fasting sample, and it's a one-step procedure, because most of our patients, if we tell them to come tomorrow for a fasting sample, then we'll definitely lose the patient, they won't come up. So we follow this DIPSI guidelines, one step, 75 grams we'll be giving, and we'll just measure the 141 value. If it's more, we are labeling it as GDM. And that is what is recommended by the national guidelines, Indian guidelines. So why to screen, when to screen, whom to screen, and how to screen, that solves this thing. The screening that is followed in India, either DIPSI. So we just get it done in the first visit, and if negative, again we are repeating at around 24 to 28 weeks. And if it's more than 140, irrespective of the fasting status, we are labeling them as GDM. And the other thing is the IAD-PHG, and in that, if a woman, like if the woman presents in the first visit with fasting more than 126 or RPS more than 200, HbA1c more than 6.5, we need to label them as over-diabetic or pre-pregnancy diabetic. Now the management. First we are dealing with the glucose management, and management is with regular exercise, walking for 30 to 40 minutes after every meal, and then medical nutrition therapy. Medical nutrition therapy has avoidance of large meals with percentage of like simple carbohydrates, 3 major meals, 3 snacks preferred, like 50% should be carbohydrate, 25% fat, 20% proteins. Low glycemic index food that release calories slowly from the gut and improve the metabolic outcomes. Now level of activity and the energy requirement, it's like 30 kilocalories per kg, and based on the sedentary, moderate and the heavy work, these are the values. Additional 350 can be given for pregnant women. If the BMI is very low, less than 20, you can add additional 500 for them. Now, how are we proceeding with it? We have labeled the person as G.D.M, we have started them on MNT, we have started them on exercise. Now we are monitoring fasting blood sugars and 2 hours postprandial. Next thing, fasting less than 95, 2 hours postprandial is less than 120. We are continuing the same thing, that is continuing your medical nutrition therapy, the same diet and exercise. Next is, if fasting is more than 95, 2 hours postprandial is more than 120. We have to either start either insulin or metformin. Metformin can be started as a first-line medication, 500 mg, and maximum to 2 grams in 2 divided doses. But if fasting is still coming more than 126, or fasting 108 to 126 with complications like macrosmia, polyhydramniosis, in those cases, it's better we directly start off insulin rather than giving metformin, again waiting and again going for insulin. Now insulin therapy, pregnant woman with G.D.M, insulin therapy. So 2 hours postprandial less than 120 we continue, and every 2 weeks we get the sugars done, and if it's less we continue the same. If it is more than 120 we start with human insulins. It's usually a premix of a short acting and an intermediate acting 30/70 subcutaneous injections 30 minutes before breakfast once a day, and dose is calculated based on the blood sugar levels. And the dose of insulin based on the blood sugar levels is, this is what we start, 120 to 164 units, 160 to 206, and more than 208 units. And then we continue to measure the fasting sugars and 2 hours postprandial every third day until if both is under control, like fasting less than 95, postprandial less than 120, we continue the same, that is insulin and MNT. If fasting is less and the postprandial is more, we increase the dose of insulin by 2 units. And if both are more, then we increase, like we have to titrate and increase the pre-breakfast level by 4 and night doses. And this we repeat every third day till the sugars get adjusted to the. Now the guidelines for monitoring. How frequently are we supposed to monitor? According to RCOG, there are total 7 values. 1 fasting, then pre-meal, post-meal, and 1 at bedtime. But ACOG recommends 4 times, that is 1 is fasting, others are post-meals. And then monitoring. So long-acting insulin. Now if we have a fasting sugars, if it is more, that can be due to 2 phenomena. This can be because of either, this may result because of inadequate insulin dose. Alternatively, it can be because of nocturnal hypoglycemia leading to rebound hyperglycemia. That is known as Simogi phenomena. In this case, the insulin dose need to be reduced. And there is another phenomena known as Down's phenomena, in which the early morning rise of cortisol and growth hormones, they lead to an increase in the blood sugar levels. In this case, you need to set the dose of insulin. So that's the reason why a midnight, if sugar is not under control and if the patient is rising in the morning with the hypoglycemia, sweating, these symptoms, then we should do a midnight 2 a.m. sugar. Now the target blood glucose levels are fasting less than 95, 1 hour post-meal 140, 2 hours is less than 120, and it should be maintained above 72. Now, this was regarding management of the blood sugar levels. Apart from that, what we are doing HbA1c every trimester, and with each visit we have to do the VP evaluation because hypertension is associated and urine albumin. Then fundoscopy is mostly for the type 1 diabetes pre-pregnancy, first antenatal visit and again at 28 weeks, and basal ECG to rule out any cardiac complications. Now, a multidisciplinary approach with structured regional diabetic and antenatal clinics is required. Patient education is very important because we need to give them booklets, because not only hyperglycemia, it's the hypoglycemia that we are worried about. So any symptoms of hypoglycemia must be explained in each visit, and daily fetal kick count should be explained. Now, monitoring of the fetus. Fetal complications are linked to suboptimal glycemic control. The first trimester, aneuploidy screening, early screening to rule out any chromosomal anomalies. And then second trimester, along with the TIFA, we can get a quadruple marker. Then again at 24 weeks, we need to get a 2D echo, fetal 2D echo. Now, growth monitoring. Growth scans can be started from 28 to 30 weeks. And then risk associated with hyperglycemia are large for gestational age infants, macrosmia babies, shoulder dystocias, and all these are risk associated. So we need to start growth scans, and you have to maintain a gap. Like, don't get a growth scan every week or 10 days. You can get it done in 2 to 3 weeks. 3 weeks time is required to see any changes in the growth. So 2 to 3 weeks, if you are worried about the LICA, you can get it done in every week. And these are the sonography markers predictive of shoulder dystocia, that is abdominal circumference to bipyramidal diameter ratio more than 2.6, humeral pad fat thickness, and cheek to cheek diameter. So this is associated with risk of cesarean delivery. Now, fetal well-being. The most important thing in GDM is daily fetal kick count. That's the most important thing, and it is advised, especially near term. After 34 weeks, it's very important. And antenatal testing, NST, that is non-stress test or biophysical profile, you can start from 32 weeks and can be done weekly or earlier if indicated. Now, timing of delivery. Again, different guidelines by different associations. RCOG, they have a bit conservative approach. They induce labor if for uncomplicated GDM managed on diet after 40 weeks. But and if it is like induction for GDM management, pharmacotherapy or on insulin by 38 weeks. According to Government of India, the guidelines are for elective cesarean at 39 weeks. Now, during labor and delivery, so these are according to the Indian guidelines. GDM with good control of blood sugars, you can wait on diet only. We can wait by 39 weeks. If it is on diet plus OHA, then we can wait till 38 weeks. If on insulin, then 37 completed weeks. And if associated with other complications, then it should be individualized. Macrosmia baby, that is more than 4 kg, consider a primary cesarean section to avoid risk of shoulder dystocia. Now, how will we manage during labor? So, if we are planning for induction or if we are planning for a section or the patient lands in labor. So, once the patient is, we are planning for induction, so night dose, they can take off insulin and they can have the normal meal. But the next day morning dose, we are omitting of insulin or OHA, and then we monitor sugar every 2 hourly, IV infusion with NS and regular insulin according to the blood sugar level. So, these are the values. If it is between 120 to 140, 4 units at 100 ml per hour, if between 140 to 186 units, and if it is more than 188 units. And target blood glucose level should be between 72 to 126. It should not fall less than 70. Now, for post delivery glycemic control, day 3 sugars are usually sent fasting and post lunch, and for uncontrolled sugars who are on diabetic post-op, we usually do while the patient is on NBM, we keep them in fluids, and with the sliding scale we titrate the sugars. And then post-delivery, after 6 weeks, we can tell them to follow up with GTT, 75 grams glucose after 6 weeks postpartum. If it is more than 126 fasting, then we can label them as diabetic and they require further follow-up. Normal if it is less than 140. Now, postnatal care continue. This is breastfeeding. Breastfeeding is associated with hypoglycemia, so we have to reduce the dose. And these are again the neonatal complications that can occur after delivery: hypoglycemia, hypocalcemia, and that affects about 30% of the newborns. And these gestational diabetes mellitus mothers, they have the risk of developing type 2 diabetes in 15% of the cases. And the neonates, they also have the increased risk of childhood obesity and increased risk of chronic diseases associated with that. Now, the challenges that we suffer are insufficient healthcare resources, because there is shortage of professional and diagnostic facilities that impact the effectiveness of the GDM management. Patient compliance, because we require regular follow-ups every 2 weeks, sugar monitoring and all. So, economic restraints, social accessibility, these issues are there. And then lack of conclusive evidence. There is no definitive strategies like which approach is the best or which approach will work for everybody. So there are not definitive guidelines regarding screening and management. And then individual approach. Clinicians should base decision on evidence while adapting to strategies. So in low and middle income countries, universal screening is preferred based on DIPSI. And in conclusion, it requires a comprehensive approach of diabetes. In conclusion, effective antenatal care, necessities for stringent glycemic management with dietary interventions, insulin, oral hypoglycemic agents is required. Monitoring of complications is necessary, and comprehensive surveillance is important, and timely delivery. Thank you.
Thank you for that excellent talk, madam.
Thank you.
And thanks for using their logo in your PPT. I have one question. Are there any preventive advice that you give to patients or mothers who are at risk of developing gestational diabetes?
Most that we come across is weight gain, pre-pregnancy weight. So pre-pregnancy more than 25 BMI is associated with development, and pre-pregnancy PCO, that is also one of the risk factors. So if we can reduce these things like with dietary management and exercise, and that itself reduces the risk of development of diabetes.
Madam, is there any risk for the children of diabetic parents who are pregnant and they genetic predisposition
Yes.
for developing diabetes, and they have developed gestational diabetes?
Yes, there is a predisposition. There are many theories linked to that, because maternal hyperglycemia is stimulating the fetus. So the insulin, the changes that occur, so the pancreas produces more of insulin, it acts more like a growth hormone. So there's a long-term correlation to that, because the in utero environment can affect later on. It can lead to later on in life complications like diabetes, coronary artery diseases, and hypertension. So there is a link to that.
And someone with over diabetes planning for pregnancy.
Yeah.
So, उनके targets are different than the general population of fasting post-HbA1c.
No, the targets are like these are the main targets. Your fasting should always be less than 95. Okay. And your HbA1c less than 6.5, and your random blood sugar should be less than 200. Why? Because there is an association with risk of anomalies. So if HbA1c is more than 8.5, there is risk, and if it is more than 11, we usually advise, like we have to advise a couple for termination, because increased risk of cardiac anomalies and all is there. So the target blood glucose level should be 95. But like even if it's first trimester and if any fasting sugars is more than 126, then rather than GDM, we label that as over diabetic pre-pregnancy, and we start them directly on insulin. We don't wait like the stepwise approach. If the sugars are only between 95 to 126 fasting, then we can wait and see, like we can give a time of 2 weeks. Okay, you do the diet, you do the exercise, you come back again like that. But if it is more than 126, random sugars more than 200, or HbA1c more than 6.5, better to label them as over diabetic and start off insulin.
One patient is already a diabetic.
Yes.
Is not pregnant yet. Is
Planning for So target blood sugar should be that only. Like fasting should be less than 95 to 100. That is the fasting range, and postprandial 140. That is the cutoff.
And if they are on other drugs other than metformin and
Yeah, that should be as soon as the pregnancy is confirmed, we change them to insulin. Before that, they can take, and usually on the first visit, we get the fasting postnatal and HbA1c, and based on that, we change. Because only metformin, previously they used to use glyburide and all also, but there's no sufficient data. So right now, only metformin is safe, and that too, we are using them for G.D.M who develop later after 20 weeks. For over diabetes, that will not be that effective. So we have to, if they are already on insulin, we have to continue on insulin, or not on insulin, we have to change them. And if there are any associated, like if they are hypertensive, then we have to change those drugs also, because AC inhibitors and all we can't give in pregnancy. Okay, thank you. Any questions? Okay, then thank you.